XYZ, a 22-year-old lady who was referred from health clinic because of iron deficiency anemia. Her chief complaint was lightheadedness, and the cause was believed to be due to her heavy menstrual loss. Her latest HB, as shown here, was 6.9 gram per deciliter, and her iron studies was supportive of iron deficiency anemia. In your view, what would be the best course of actions? I'm Dr. Tan, and today we are going to learn about safe transfusion practice, keeping it safe. I hope the scenario that I provided you earlier have already put you on your thinking cap. This is very crucial because the subsequent part of the lecture will be mainly sharing with you about the practical tips where you have to actively try to relate it back to the scenario that are given to you or cases that you're seeing in your day-to-day clinical practice. If you are new to this channel, I would strongly recommend you to go through the other videos which could be found in the playlist. And for your information, the main objectives of having these channels is to help our junior doctors to have a stronger foundations in clinical medicine. This is the lecture overview. We would begin the lecture by first talking about the types of blood products, and also we will go in depth about the treatment options for iron deficiency anemia. As you know, IDA is actually the commonest cause of anemia worldwide. Most importantly, we will go through with you the rules of thumbs for transfusions, and also we will discuss about transfusions in certain special populations. And as always, we always end the lectures by giving you further reading materials so that you can actually read more about these topics at your own time. Before I jump into the nitty-gritty of the lecture today, I would like to first share with you about the blood components that we can derive from 1 pint of whole blood. As you can see here, a bag of whole blood could be separated into so many blood components, and each component would have different clinical indications. It's totally beyond the scope of this lecture to talk about the indications of each of the blood components. So in the interest of time, I would just be talking about packed cell transfusions during this lecture because this remains to be the most commonly used blood products in clinical practice. Other products which include platelets, FFP, and also cryoprecipitate, cryosupernatant, granulocyte transfusions, and also others minor components like hemoglobin, immunoglobulins, PCC, plasma-derived factor, and concentrate perhaps should be discussed in another lectures. For your information, iron plays many important biologic functions in the human. This function is not just limited to erythropoiesis, it also plays an important role in energy productions, DNA synthesis, cell proliferations, and also most importantly, iron also has an effect on the host immune system. Now let's talk about the symptoms of iron deficiency as well as the common adverse effects. Before I go into the detail, it's important for you to know that the symptoms of iron deficiencies comes in a spectrum. So the symptoms normally will start when the subject has a low iron store, and at the end of the spectrum where the iron is almost depleted, only then the patient will develop anemia. So when the person is suffering from iron deficiencies, what they will experience are commonly weakness, fatigue, difficulty in concentrations, which are generally rather non-specific symptoms. And also, importantly, in children, it may also contribute to delayed mental and motor development if this iron deficiency wasn't tackled. And among our pregnant mothers, it will also have an adverse pregnancy outcomes if the iron deficiency wasn't treated. Like what I've alluded earlier, an iron deficiency state could actually impair the innate as well as the cell-mediated immunity of the host. And last but not least, a severe iron deficiencies would also cause heart failure and with anemia being at the end of this spectrum. So therefore, it's very important for you to recognize the signs and symptoms of iron deficiencies at the earlier stage so that it could prevent the late complications. It's like stress that iron deficiency is actually everyone's business because patients with iron deficiency will come to you in a different setting. So first, let's take a look at the outpatient clinic as the main bulk of patients will first present to our outpatient doctors. As I've alluded earlier, the symptoms could be rather non-specific as well, depends on the severity of the iron's deficiencies. But very commonly they come to you because they are fatigued, tired, or sometimes just tell you that their quality of life is impaired. So please have a high index of suspicions whenever you come across such a group of patients, and do order an iron study to exclude iron deficiency. If iron deficiency is diagnosed, do always look for the root cause. Next, let's talk about our patients with advanced CKD disease or those with established end-stage renal failure. Very commonly, they will suffer from either functional or absolute iron deficiency because they are actually in a state of perpetual inflammations due to the chronic disease. They will actually impair the iron absorption ability. Moving on, let's talk about patients with gastroenterology disorders. I'm very sure that all of you are aware that iron deficiency anemia is actually one of the most common presentations for them who actually have occult GI bleed. Hence, please take IDA seriously, and always you need to consider could it be due to occult GI bleed if the cause isn't evident. IDA is also very common among our ONG's patients, and for patients with chronic heart failures, IDA very commonly will coexist as well. And it has to be treated because studies show that IDA is actually a non-precipitating factors for heart failure. Also, the same goes for surgical patients and oncological patients. IDA is equally prevalent as well. So before I talk about how to diagnose IDA, also known as iron deficiency anemia, let's learn how to diagnose iron deficiency first. So this will be the common parameters which will be given to you when you order an iron study, which includes of your serum iron level, the TIBC, your TSAT, which actually refer your transferrin saturation level, as well as the ferritin level. So in clinical practice, the most important parameters they will look for will be your TSAT, which is your transferrin saturation level. It will be depicted in percentage because it derived from serum iron divided by your TIBC times 100%. So for anyone with a TSAT of 20% and below, indicates that the patient has suffered from iron deficiency. Of course, TSAT is not the only parameters. You can also diagnose a patient with iron deficiency anemia based on the serum ferritin level. Okay, bear in mind that ferritin also acts as an acute phase reactance, and it could be raised in patients with chronic illness or inflammatory state. For example, like I told you, patients with renal disease, right? Their ferritin count may not be as low as a normal being, even though they are actually in a state of iron deficiencies. But in general, if this ferritin level is more than 100, then we consider the patient has an adequate store of irons. For those iron level range between 30 to 100, it will be considered as having a low iron stores. And for patients with serum ferritin less than 30, then they will be considered as iron deficient. Well, this is just a very simplistic display of on how to diagnose IDA. With the presence of anemia and also evidence of iron deficiency, then you diagnose them to have IDA. But where's the catch here? I think the answer was already given to you earlier. So ferritin could also be raised because of the underlying chronic illness or inflammatory state. For example, like our CKD or end-stage renal failure patient. So having a normal ferritin doesn't exclude IDA. Sometimes we also need to look at the full blood pictures as well as other parameters as well. And also, your patient has received recent transfusions. It recommended that your iron measurements be taken at least more than 24 hours after the last transfusions. And equally, if patient is on hematinics or one, ideally you should withhold the hematinics for around 2 days before you measure the iron levels. And also, the best time to measure iron level will be after an overnight fast. Iron deficiencies only represent the tip of the iceberg, so diagnosing IDA alone is insufficient, or else should always look for the underlying cause of the IDA, because by treating the root cause, it can prevent IDA and also it will improve the quality of life of our patients. The causes of IDA could be broadly divided into physiological causes, environmental causes, pathological causes, or genetic causes like your iron refractory iron deficiency anemia, IRID. Because of the long list of causes, I'm not going to bore you by going on and on about the causes. In fact, I've included an article in the description box. You can go through the articles and learn about these courses are IDA at your own time. As I promised you earlier, I'm going to share with you what hepcidin is. Hepcidin is actually a very important hormone or protein that plays an important role in maintaining the total body iron within the normal range. So the hepcidin protein was primarily excreted in the liver. Hepcidin will be released or upregulated under two circumstances. The first circumstance will be when the plasma iron level in the human body was increased or high, then hepcidin will be released. It will cause reductions of iron resorption from the gut and also reductions of iron recycling from macrophages, hence reduce the iron in the circulations. Unfortunately, hepcidin is also an acute phase reactant. For example, in patients who are in inflammatory state because of the chronic illness, hepcidin production will be induced as well. So when this happens, it will cause a similar process, but ultimately, the iron level in the circulation will be reduced to an extent that it will be insufficient for erythropoiesis. So when that happens, it will give rise to either functional iron deficiency or absolute iron deficiency. Finally, when it comes to the general principles in IDA management, I hope at this stage we will have already taken a good history, performed examinations, as well as some essential basic investigation in your hand to guide you. The clinical decisions on how rapidly to increase the hemoglobin depends on a few factors, where I will discuss in depth with you in the subsequent part of the lectures. But broadly, there are three methods on how to increase or optimize the patient's hemoglobin. It is no-brainer that transfusions will be the fastest way to optimize your HB. But however, in nowadays contemporary medicines, we try to avoid transfusions unless it's clinically indicated. Because why? It's very simple. Because we have an equally effective and rapid way of bringing up the HB, which is your parenteral ions, which we're going to discuss in a while. And also, you have a much lower way to optimize the HB. We try hematinics, also known as oral iron therapies. Even though you have already optimized the patient's HB within a short period of time, bear in mind that what you have treated is just to increase the HB. You still need to supplement the patient with oral hematinics for around 3 to 6 months in order to replete the patient's iron store. And all these methods have to include dietary modifications as well. So now I'm going to talk about hematinics, which is oral iron therapies, a very common prescriptions. Just give you a few quick facts about this treatment. So the recommended daily dose for adults with IDA or iron deficiency is about 100 to 200 mg of elemental iron per day. That gives us the questions, how much elemental iron does our ferrous fumarate tablet contain? So the answer is actually over here. So one tablet 200 mg is there. So for every 200 mg of ferrous fumarate, it only contains 65 mg of elemental iron. Therefore, it makes clinical sense that normally in patient with IDA or iron deficiency, we will provide double hematinics. What it means is that you will give 2 tablets of ferrous fumarate. On the other hand, if the patient is being given zinc copper, equally you should top up with 1 tablet of ferrous fumarates in order to meet the 100 to 200 mg of elemental iron requirement per day. It's a slow effect and usually take months to resolve the anemia, and also common side effects that are reported by patients would be like constipations or the bad taste and so on and so forth. But anyway, it's a very safe treatment options. If patients there's no urgent need of developing HB, you can consider these treatments. Also, one effective way to boost iron absorption is to co-administer ferrous fumarate tablets or any iron supplements together with vitamin C. Just now we have talked about oral hematinics. Now we are going to switch gear and I'm going to talk about parenteral iron therapy. I wouldn't call this intravenous or IV iron therapy because some of the iron therapy could actually be administered through intramuscular injections. Let's take a look at the indications for parenteral iron therapy. Because the first indication would be where there is a clinical need for rapid iron supply, And the second indication will be in patients who cannot tolerate oral iron therapy or who are non-compliant. Like I told you, oral hematinics, some patients they could not tolerate because they develop constipations, because of the taste, and so on. And also in patients who have an active inflammatory bowel disease, where it's proven that oral hematinics or iron preparations are actually ineffective. And also other considerations as well, such as functional iron deficiency anemia or absolute iron deficiency anemia among our end-stage renal patients because of the chronic or perpetual inflammatory state, right? Oral hematinics will not be effective. Or among pregnant mothers where the IDA was diagnosed only near the third trimester, which is like already near to delivery, sometimes to circumvent transfusions, we can give a parenteral iron in order to boost the HB prior to delivery. Also, it could be used in our patient blood management for our surgical patients, like during pre-op assessment, in order HB is low, you can actually boost it with parenteral iron so that you can optimize the HB safely before operations. As listed here, these are the examples of parenteral iron formulations. For example, ferric gluconate, ferric carboxyl maltose, iron sucrose, as well as low molecular weight iron dextrans. In order for you to have the better learning experience, I have included this document, which is prepared by our Dr. Ananti and Dr. Jamila, our distinguished hematologists, where it will serve as a quick start guide for you to diagnose iron deficiency and also in knowing how to use intravenous iron safely. So different parenteral iron formulations has their own strengths. So basic considerations for myself would be that I need to know whether the parenteral iron formulations has a ceiling dose or not. If there's a ceiling dose, it means that the patient may need to have their total dose requirement to be divided into multiple doses, as opposed to those that do not have a ceiling dose, you can give the total requirement within a single injections. Also, very importantly, I will take into the patient's allergy history as well, and then ultimately depends on the availability of drugs in the setting. So you may wonder, right, how do we get to know the total amount of iron to be replaced? So most of us will refer to this Ganzoni formula, or sometimes just refer to the drug insert. There will be a very nice table there for you to calculate the irons required. Finally, I come to the last part of the lecture, which is about safe transfusions, or in other words, safe Paxil transfusions. What are the rules of thumbs? As you know that Paxils are actually life-saving treatments. Of course, when I'm talking about this, I'm not trying to discourage Paxil transfusion. I'm just to encourage you to have a safer Paxil transfusion practice. As you know that nowadays we have so many other alternatives to boost the patient's HB, provided that there's no immediate urgency, to optimize the HB. So let me take you through one by one. What are the general considerations or rule of thumbs that I will go through before I decide to call for transfusion? The first rule is that to understand or to know the trajectories of the HB trend. So in my clinical practice, most of my patients actually came to me with chronic anemia, meaning that the anemia has been there for quite some time. So most of the time, there's no urgency to boost the HB count unless patients have some associated important complications, for example, like anemia associated angina, then perhaps I will consider transfusions. Or else I'll try a safer method, for example, like either parenteral irons or oral hematinics to build up the iron store as well as to improve the HB counts. On the other hand, in another extreme, I would say that if you have a polytrauma patient that is exsanguinating, bleeding away of you, then of course transfusion will be based on some clinical judgment. You will not ask for the FBC to guide you. For your information, in patients that are actively bleeding, once a HB drop, those are actually late signs. So you need to know and understand whether is it a chronic anemia or acute anemia that is bleeding away that you must transfuse. Another important consideration will be our patient cardiac reserve. As a rule of thumb, if the patient have a normal cardiac reserve, the triggering threshold for transfusion will be 7 grams per deciliter and below. On the other hand, on patients with impaired cardiac reserve, then apparently the threshold of transfusion will be lower. So you'll transfuse if the HB is less than 8 grams per deciliter. All in all, it's about risk and benefits analysis that have to be done by the clinicians in order to decide whether is transfusions really warranted or not. So all these are just general guide. So another factors to consider will be our patient's hemodynamics. Also, we will consider whether the subjects have a potential for erythropoiesis or not. For example, you are dealing with a patient with beta thalassemia major, then apparently transfusions would be one of the only methods or one of the only few methods to improve the patient's HB. So lastly, you also need to consider is the patient having ongoing hemolysis due to autoimmune hemolytic anemia or not. It's well established that transfusions will actually aggravate IHA. But however, being said, if you feel the indication is justifiable after going through the risk-benefit analysis, you may proceed with transfusion, but it has to be done in close collaborations with your blood banks or what do you call that, with your transfusion specialist as well as with your local hematologist. I must make a point that blood is donated, but it is not free. And the cost of 1 pint of Hepcidin is approximately around 500 ringgit. And a pint of blood would only be able to raise approximately about 1 gram of HB. But of course, for those who have practiced long enough, you can actually quite confident say that sometimes it's a bit hard to predict, isn't it? It doesn't always follow the 1 pint 1 gram rule. Sometimes 1 pint can bring you up more than 1 gram. Sometimes it doesn't bring up if the patient still having active bleeding or what. But anyway, it's always a safe practice to repeat the ABC post transfusions in order to decide whether further transfusions are needed or not. So another topic is to talk about how to reduce risk of fluid overload in at-risk individuals. So for example, you have a patient with congestive cardiac failure came to you because of anemia-induced MI, and you decided to transfuse. So there's a few measures that you can take in order to mitigate the risk. For example, if the patient is on dialysis, then of course you can dialyze during HD at the same time, extract the extra fluid during dialysis via UF ultrafiltrations. And also, you can also give a much slower transfusions. For information, the slowest you can give is around 4 hours. Beyond that, there's always a risk of contaminations. Also, lastly, always give IV laser in between transfusions for patients who are at risk of fluid overloads. So a quick points, I think FFP is a plasma, right? And all you know, so it actually carries a higher risk of fluid overload. For FFP, you can actually ask for split bags, say if needed. I have almost come to the end of my presentations already. For those who have not heard about the 10 commandments of transfusions, I would urge you to spend 1 minute of time to go through these slides where it encapsulates nicely to you about what safe transfusion practice entails. Thank you for your time, and you think this video has benefited you, please give a like and also share it with your friends, they will benefit from this video as well. And the next video, we're going to talk about clinical examinations, which is very important components, whether for your undergraduate trainings, for your houseman's assessment, and also for your postgraduate trainings. So stay tuned and look forward to see you again in the next video. Thank you.